two stories to tell, because I've got a Welk story to tell and I've got a Tower Hamlets story to tell. Right, Welk is Waltham Forest, East London, the city. But actually, we're really Tower Hamlets, Newham and Waltham Forest. And we are that because we mapped the Bart's Health footprint. That's been a real challenge for us, because historically we were East London, the city, so that was not Waltham Forest, but City and Hackney. We've had a very, very long-standing pre-primus performance improvement body in general practice. We're all EMIS. We all stream data into a data warehouse. We've had long-standing GP-based data dashboards for quality improvement. And so we're used to working that way. So Tower Hamlets and Newham have that model. And Waltham Forest are completely different. They belong to outer North East London. They have GPs on, I think, 3 or 4 different systems, and they use health analytics. All 3 of the Welk boroughs had attempted community virtual wards of various sorts. I think we're an absolute wonderful example of bundles of spaghetti, as Mike describes. There's been lots and lots of work around technological things. We've got HIE-MIG, we've got Orion and Pilot, we've got health analytics, we've got data warehousing, we've got all sorts of bits and pieces. And I would absolutely be with Mike indicating that that is not the way to do it. So we're quite a long way down, much further down the route of Greenwich. But actually we're realising that we've got ourselves in a bit of a muddle. So the first thing we did around Welk was Bart's Health basically didn't want to talk to individual CCGs, which is fair enough. So that was a really good forcing us into a room together. And what we have done is we have a really well-attended, Welk-wide informatics group, and we have now, painfully, agreed a shared strategy. The shared strategy is definitely owned by the health partners, so all of the health delivery trusts and all of the CCGs except City and Hackney have been part of that. 1 or 2 of the boroughs turned up but really didn't give a lot of contribution. And London Ambulance were there for 1 or 2 of the meetings, but it was pretty tangential. So, we've got a strategy. We've got, I would say, real challenges around, a lot of it's to do with money. And actually, in a funny way, we really, whilst Tower Hamlets are massive losers on the GPIT levelling down, Waltham Forest are massive winners, and that's actually a real enabler, because across the country, if you don't have basic GPIT in place, we can't do this. We actually bought Orion nearly 3 years ago, and we're in pilot now, because when we went to join up, we found that the community services weren't keeping electronic records. So actually, one of the really core pieces of strategy is records are electronic, not paper. But actually, it's a bit of a shock when you discover that there are still an awful lot of people who are not using electronic records. I would say that the main piece of learning for us across the system, I'm going to tell you a little bit specific about Tower Hamlets in a minute, was that when we already had data warehouse, last year was information governance year. And what we have chosen to do, health analytics haven't yet, but the Tower Hamlets are new, we decided that people who were part of our integrated care programme, and we were able to run risk scores centrally through the data warehouse and then cascade it back to practices, so we can risk score across the whole borough. We decided we were going to actively opt in consent people to this programme, which initially we thought, oh God, what a waste of time, what a bore. But actually it's been a very interesting piece of learning, and I think one of the things where I would say that our learning is tangential to the document that Mike wrote that we all saw, is actually I think we really need to focus on the bit when people are well. So actually the consent process has been very, very interesting, because the learning has been, what we really want to people is about service offer, and beginning to offer some stuff around self-management. So you might think people in their last years of life with complex comorbidities aren't up for a lot of self-management. Well, actually, the conversations around advanced directives, lasting powers of attorney, about their wishes and choices are really, really important, and they've really stimulated conversations between GPs and the families, as well as GPs and the people living with these complex needs. So I would be saying that for us has been a painful journey. We've got all codes sorted. Candice managed to get hold of the code specifically for social care, but I think it's an iteration around the original document was very much about us trying to do data processing properly, and I actually think documentation that's actually much more person-centered about, the the one you are going to die. In fact, we were laughing last week because somebody was saying that they met this patient and said, well, if I die, and it's like, you grasp this. That's one piece of learning. Then there's a very separate Tower Hamlets specific bit. The reason I know Gillian is that Tower Hamlets was one of the pilot sites for Year of Care. And Year of Care was a diabetes-centred project that ran 2007 to 2010. And it was about delivering what is now being called person-centred care and support planning. And that is not, I think a lot of what you're seeing in the documentation that's been circulated today is what I would call team around the patient plans. And they are of great value, but they're not really person-centred. So one of my challenges from the kind of work that we've done at Tower Hamlets, we are, as well as doing the usual risk stratification cascade down to intermediate tier services as needed, we're also running what we're calling GP coordinated care, and that's actually around a clinical basis, and it's really, really, really about trying to engage people to actually self-manage, despite the fact that they have multiple long-term conditions or dementia. There is an awful lot that people do and their communities can do for themselves. And I think it's a slight challenge in the language, you know, you're talking about patient journey. Patients! Actually, these are people and they want to stay independent. So I think that's a challenge, and again, that's a tangent across. That doesn't in any way...
Can I just respond?
Yes.
All we've done today is pick one of the journeys, crisis.
Absolutely.
I absolutely agree with you. You take all the different perspectives and views of it. But you end up the information requirements probably being very much the same.
Well, the other piece of work we've done, because we procured Ryan a long time ago, we've also done a business requirements workshop across the patch. And actually what was really encouraging is that the business requirements are very, very similar. So in fact, there isn't a problem in terms of when you get down to the data. So exactly. The local authority are really up for this. So in terms of the stuff that we as care deliverers need to know, it's actually quite straightforward. I think the issue, I would go back all the time to the strategic stuff, and that's why I'm putting the challenge on the table about these are people that we're looking after, not patients.
Yes.
Good.